Welcome back, Focus Learners, to another edition of The Explainer. Today, we're tackling a topic that is absolutely high yield for your board exams, especially if you're gearing up for NEET SS or INISS. We're talking about rheumatoid arthritis. Now, I don't want you to just memorize a laundry list of symptoms. Instead, I want you to really understand RA as a perfect storm. It's this devastatingly precise collision of genetic susceptibility, environmental triggers, and honestly, profound immune dysfunction. Because, by the time a patient actually complains of that morning joint stiffness, wow, this storm has already been brewing for years.
Okay, let's dive into this. Here is our bench-to-bedside roadmap for today. We'll start with triggers, genetics, and environment. Then move into immunopathogenesis and the cytokine storm. Look at joint destruction, clinical manifestations, and wrap up with the ACR/EULAR diagnostic criteria.
Starting with Section 1, Triggers, Genetics and Environment. So the foundation of this perfect storm actually begins well before a patient ever sets foot in a clinic, long before they feel even a hint of joint pain.
All right, here are the 3 absolute most exam-critical genetic markers you've got to know. First up is HLA-DRB1, which encodes an MHC class II molecule. This is the big one, guys. Next, pay really close attention to PTPN22. This gene regulates T and B cell function, and a gain-of-function mutation here leads to abnormal thymic selection of autoreactive cells. And here's a fascinating piece of trivia to tuck away for your exams. This specific risk allele is completely absent in patients of East Asian ancestry. Crazy, right? Finally, we have PADI4. This encodes an enzyme that converts the amino acid arginine into citrulline. Lock that conversion into your memory, because citrullination is literally the cornerstone of RA pathogenesis.
Now, to truly grasp that HLA-DRB1 risk, we have to talk about the shared epitope. This is a specific amino acid sequence at position 70 to 74 in the third hypervariable region of the HLA-DR beta chain. So why does this matter so much? Well, think of this specific structural pocket like a genetically loaded gun. When proteins in the body are post-translationally modified, like say being citrulinated, this shared epitope binds to those modified peptides with just incredibly high avidity. It basically presents them directly to the immune system and says, hey, look at this foreign invader.
Now, what's really interesting here is the dramatic multiplier effect of the environment. If you carry that shared epitope allele and you don't smoke, your baseline risk of developing RA is about 4 to 6-fold higher than the general population. But if you combine that exact same genetic profile with some smoking, that risk skyrockets to a massive 20 to 40-fold increase. It's huge. This wild synergy led researchers to a groundbreaking hypothesis. The initial trigger for RA might actually happen in the lungs. Basically, smoking induces chronic inflammation and promotes the citrullination of proteins right there in the lung tissue. So you're essentially creating the exact autoantigens that your genetically primed immune system is just waiting to attack.
Moving on to Section 2, Immunopathogenesis, the cytokine storm. So what exactly happens after these initial triggers? Well, you get a massive, completely dysregulated response from the adaptive immune system.
Down at the cellular level, this is where the magic, or rather the destruction, really happens. CD4-positive T cells are activated by antigen-presenting cells right inside the joint. And remember, this requires 2 distinct signals. Signal 1 is the T cell receptor binding to the MHC peptide complex. Signal 2 is the co-stimulation from CD28 binding to CD80 or 86. Once those 2 signals connect, boom, the T cells differentiate into Th1 and Th17 subsets. You can think of these T cells as the generals of the immune system. They're coordinating this massive attack by activating macrophages, fibroblasts, and B cells, which then just flood the joint with inflammatory mediators.
And those activated B cells, they mature into plasma cells and start pumping out 2 absolutely crucial autoantibodies. First, anti-citrulated protein antibodies, or ACPAs. Tie this directly back to what we literally just talked about, the PADI4 gene converting arginine to citrulline, and smoking triggering that citrullination in the lungs. The immune system is now mass-producing antibodies against those specific altered proteins. Second, we have rheumatoid factor, which targets the Fc portion of your own IgG antibodies. Together, these form massive immune complexes inside the joint space, fixing complement and basically throwing gasoline on the inflammatory fire.
The end result of all this cellular crosstalk is a full-blown cytokine storm. The absolute pivotal driver here is TNF-alpha. It upregulates adhesion molecules to drag more leukocytes into the joint, and it heavily stimulates bone destruction. We also see really high levels of IL-6 from macrophages and fibroblasts, and IL-17 from those Th17 cells we just mentioned. Now, I really want to emphasize something here. Memorizing these cytokines isn't just an academic exercise. This is the absolute bedrock of modern rheumatology. While our foundational DMARDs, methotrexate, sulfasalazine, leflunomide, while they remain vital first-line therapies, our modern biologic therapies are engineered specifically to target and neutralize these exact cytokines, especially TNF-alpha and IL-6.
All right, Section 3, joint destruction, bone and cartilage. We've seen the storm brewing on a molecular level, but now let's shift our focus to the tissue-level consequences, because the collateral damage of all this immune warfare is the physical destruction of the joint itself. So the crucial point here is understanding the physical manifestation of this inflammation, which we call the pannus. Normally, the synovial membrane is this thin, delicate little layer, but in RA it becomes a hyperplastic, thickened, almost tumor-like mass of fibroblast-like synoviocytes and reactive vascular tissue. And this pannus doesn't just sit there benignly. It aggressively invades the underlying mineralized cartilage and bone. It acts almost like a parasite, just consuming the joint from the inside out.
But here's the thing, the pannus doesn't actually eat the bone by itself. It recruits osteoclasts to do the dirty work. Let's step methodically through this pathway because it is highly testable. First, monocytic cells in the synovium are exposed to MCSF and rank L. Cytokines like TNF-alpha and IL-6 heavily upregulate this rank L. This exposure causes the monocytic cells to fuse into polykaryons, which are basically pre-osteoclasts. They then mature into fully activated osteoclasts with these ruffled membranes that latch right onto the bone and secrete cathepsin K. That's an incredibly potent protease that cleaves collagen and just dissolves the bone matrix.
It's so important to realize that bone damage in RA isn't just one-sided. It's a dual-action catastrophe, a total, complete imbalance of normal bone remodeling. On one side, you have rank L acting as the accelerator, driving this aggressive bone destruction via those osteoclasts. On the flip side, TNF-alpha upregulates a molecule called DKK1. DKK1 acts as a powerful brake on the Wnt pathway, and since the Wnt pathway normally promotes osteoblast differentiation and new bone formation, DKK1 effectively shuts down the body's ability to repair the damage. It's brutal. You're simultaneously flooring the accelerator on destruction and slamming the brakes on repair.
Moving to Section 4, clinical manifestations of RA. Let's zoom back out from the microscopic level and go to the bedside. How does this perfect storm of genetics, immune complexes, and bone destruction actually present in the human being sitting right there in your exam room?
Well, this brilliantly illustrates the physical reality of all that abstract science we've been discussing. Notice the really prominent swelling and the early stages of subluxation in the metacarpophalangeal, or MCP joints. This is a classic hallmark of established rheumatoid arthritis, that symmetric involvement of the small joints of the hands, and it's a direct result of that aggressive pannus formation we just outlined.
When you're assessing the patient, you're looking for that polyarticular, symmetric distribution. Wrists, MCPs, and the proximal interphalangeal joints, the PIPs. Now here's a massive, high-yield differentiator for your exams. RA characteristically spares the distal interphalangeal joints, the DIPs. If the DIPs are heavily involved, you really should be thinking osteoarthritis, not RA. Beyond the joints themselves, up to 40% of patients develop extra-articular manifestations, things like subcutaneous nodules and interstitial lung disease. Interestingly, though, severe systemic complications like Felty syndrome and rheumatoid vasculitis are actually decreasing in incidence today, which is just a fantastic testament to how incredibly effective our modern targeted biologic therapies have become.
Which brings us to Section 5, diagnosis using the ACR/Euler criteria. We've seen the pathology, we know the clinical signs, now we transition to the final step of the clinician's journey, formally classifying the disease so we can actually initiate those life-changing treatments.
Let's move to the criteria and see how this all builds together. The 2010 ACR/Euler table perfectly synthesizes everything we just learned into a clean, definitive scoring system. Just look at how heavily weighted these scores are. Joint involvement gives you up to 5 points, heavily favoring those small joints of the hands we just looked at. Serology gives you up to 3 points for high positive RF or ACPA, directly reflecting that genetic and environmental trigger pathway. Finally, you get points for abnormal acute phase reactants like CRP or ESR and a symptom duration of over 6 weeks.
When you tally up those categories, 6 is the magic number. A score of 6 or greater out of 10 is the absolute threshold required to definitively classify a newly presenting patient as having rheumatoid arthritis. Once they hit that 6, it is time to act. You want to start aggressive therapy, typically initiating with traditional DMARDs like methotrexate, to stop that pannus right in its tracks.
So we've covered the pathogenesis, the clinical picture, and the diagnosis. But before we wrap up, I want to leave you with the provocative thought about the future of this field. Recent single-cell RNA sequencing of rheumatoid joints has actually revealed that not all RA is the same at the cellular level. Some patients have a myeloid-dominant phenotype, others are heavily driven by T and B cells, and some have a really distinct fibroid signature. As we look to the horizon of rheumatology, think about this. If we can routinely identify a patient's specific synovial cell phenotype right at the time of diagnosis, could we bypass trial-and-error medicine entirely? Could we prescribe the exact, perfect, customized biologic from day one? The perfect storm of RA is terrifying, for sure, but our ability to map it and stop it is becoming just as precise. Keep that in mind as you crush your exam prep, and I'll see you on the next explainer.